Good morning, everybody. Happy Friday, May 7th. And I wanted to continue on where we left off last time. Let me just enlarge this. Um, we're going to continue with the idea of measuring effective connectivity in clinical practice, going through how this works, how it informs us in terms of intervention, and hopefully this helps to kind of clarify just basically how this works and how you can utilize this to better help your patients. So we're going to go over maybe more than one case. We'll see how we do here, how long it takes. So the first case we're going to go over is a individual with autism. This is a 15-year-old ambidextrous teenage female with some details about her presenting condition. She was adopted by her grandparents after her mother was arrested for using drugs. As a child, she showed repetitive behaviors, flapping, spinning, troubled transitions, temper tantrums, presently struggles with social maturity, rule following, poor voice control. Her voice is too loud, and social boundaries. She avoids crowds and is anxious around other people and noises. She's been prescribed Focalin, trazodone to help her go to sleep, and other medications for other reasons. She has had speech and occupational therapy as well. When she first presented to us, she was a 10th grade student, getting C's and D's in all of her subjects, and struggles greatest in reading and mathematics and science. Shows excessive talking in the classroom, is distractible, and doesn't complete assignments. When we did her neuropsychological testing, her full scale IQ was an 80. And I would imagine most of you know this, but the average IQ is 100. Anything below 90 is considered low average. She'd be at the bottom of the low average range. She showed a verbal IQ of 95, a performance IQ of 72, which means that her performance IQ based on visual, spatial, and problem solving types of analyses is significantly lower than her verbal skills. Impairments were noted on testing in attention, social perception, and mathematics, and she was extremely low in what's called matching affect. So basically what that means is she's shown a picture of people's faces expressing different emotions, happy, sad, fearful, angry, neutral emotions, etc. And she has to match them with other people showing a similar emotion. Basic tests for this has you label their emotions, but there are more complicated tests where you can match them, tell differences, whether it's the same person, different person, etc. Personality testing showed peer insecurity or social challenges and self-esteem related concerns as well. This was her eyes closed analysis of her EEG. You can see in the top portion of the image there are 9 independent components that were pulled out of a 32-channel EEG that was done. And basically the way you interpret these, typically the red areas, which are the positive flow in the EEG, and the blue, the negative. The red areas are the areas of concern, and you can see they're almost all towards the back of the brain, except in component 8, where the blue area is actually probably the greatest concern, and that localizes, as you can see below, to the right parietal region. So the dipoles below that give you a horizontal, sagittal, and coronal view of the source localization. And again, the vast majority are in the back portions of the brain, occipital, parietal regions, and especially on the right side. This is the connectivity across those areas. And it basically plots over time the Granger causality connectivity matrix using partial directed coherence as the variable. And You get a range of activity and you get to see ebbs and flows in that activity. Generally, the darker and the thinner the blue lines are, the lower the connectivity. So it's pretty clear for this individual that there's low connectivity across multiple regions that are detected. This is the same person's more typical QEEG, where on the top half you can see a Braindx analysis that shows mainly excess beta in the back of the brain and beta 2 in the right parietal temporal regions. And then the Estheretta localized to the precuneus, really in the middle parietal lobe. In alpha at about 11.7 hertz to a z-score of, it's a little hard to read, but I think it's just over 3 z-scores, so it is significant. This kind of compares the Estheretta to the dipoles. And one of the limitations of Estheretta, and this is not necessarily a criticism, but this is why it was created, is Estheretta is designed to be a solution to the problem of not knowing where the source is of the surface EEG. And it takes the EEG in total in a given frequency and gives you one specific source. So where you see these kind of crosshairs, yellow to yellow, horizontal, vertical, and black from side to side, that's the exact point that we're localizing to. When we look at dipoles, we localize each component to separate regions, and it's not just one spot or one location. So now there are multiple regions involved. We can actually measure connectivity across those regions. So it gives you different types of information and in my opinion, more comprehensive information. This is what the pairwise coherence values look like coming out of NeuroGuide. Again, doesn't matter whether it's NeuroGuide or not. And remember, we've been talking about the problem in the right back hemisphere. And interestingly, while the pairwise coherences do show problems of low coherence in most of these frequencies, they don't show them in the area where we think the problem is. But the multivariate coherence metric from NeuroRep does, especially in the alpha, theta, and beta domains, where you see the right middle to right back portion of the brain from occipital parietal to temporal regions disconnecting. So it's very interesting that the NeuroRep, which is based on using information from all electrodes, as well as our Granger causality, shows where the problem is, but the pairwise coherence really doesn't. And if you chose your neurofeedback on any of these, you might have different protocols based on that information. So that difference is critically important. And then again, here's back to the Granger causality, which shows you the problem in that occipital, middle parietal precuneus to right anterior parietal regions of the brain. And that's where we would train someone like this. But again, if we based it on that pairwise coherence information, we would probably train on the left side, not the right. So it's actually the opposite of what you would do. Okay, let's get through one more case here. Here's a case of epilepsy, a 7-year-old boy with autism spectrum disorder and a very severe form of epilepsy called Lennox-Gastaut syndrome, which is, by most accounts, very, if not untreatable, very difficult to treat through standard means. He has a history of seizures with daily events happening, takes CBD and multiple anti-epileptic medications, is on multiple vitamin intervention, very low verbal and intellectual skills, very poor focusing, memory, problem solving, sensory issues. poor safety judgment, odd behavior, outbursts, physical aggressiveness. So there's clearly some frontal lobe and limbic system involvement in all of that, and pretty pervasive concerns for this young boy. This is what his EEG looks like. And in the EEG, at least initially, you can see almost constant seizure activity. There's respites every once in a while, but this is what the entire EEG looks like when you measure it. So it's a very concerning case from that perspective. When we do a seizure and spike review, we can see these little blue and red ticks on the bottom are left and right-sided spike or spike and wave discharges, and these red areas up top are actual seizure events. So again, you can see it's happening very frequently. So this is what his independent component analysis of 19 channels of EEG looks like. We get 5 components, and they source localize over frontal brain regions almost entirely, but with one in the left temporal region down here. It's a little harder to see. And then 3 in the left frontal and 1 in the right frontal region. And this is our connectivity analysis, which is very fascinating. It shows us a pattern of underconnectivity. However, as a seizure starts to build, you see this one area switching to over connectivity, or what we call hyperconnectivity, which is what happens in a seizure event. So the communication across neuronal networks diminishes so much to the point where they separate entirely and there's no more regulation or very little regulation, and the discharges you see in a seizure become hyperpolarized across those entire regions and can even spread to other regions. And then you can see his brain after that event kind of goes back to its previous state. And this is very typical in seizure activity. So you can go from a connectivity of like 6 or 7 all the way up to 90 or 100 in a flash like this. So our goal in neurofeedback, as we understand seizure development in this way, is to treat connectivity to be higher, so that 6 and 7 to rise to 15 and 20, so that the underconnectivity pattern never dips and becomes this hyperpolarized state. And that's how you would prevent seizures from happening in the future. This is the Loretta looking at activity at 5 hertz, showing a localization right over the middle frontal and orbital frontal gyrus to a z-score of 3.7, almost 3.8, which is obviously very significant. So we know where the problem is. We have an idea of the connectivity notion of it. Again, here is our NeuroRep multivariate coherence analysis, still at the surface of the brain and still not causal like the Granger causality is, but it does use the inputs of all 19 channels simultaneously to calculate this through a principal components analysis. And we can see very significant frontal disconnections in delta, theta, alpha, and beta, almost every frequency. But in the pairwise coherence analysis, we actually see a combination of low and high coherences, mainly in delta and theta. So the question then becomes, well, what would you train? If you focused on theta, it looks like it's more hypercoherence. You might actually train coherence down, which would be a dramatic mistake, and based on our theory, a way to increase seizures. So we would never want to do that. So again, the system you use to analyze coherence and connectivity really, really matters and will dictate your protocol and likely dictate your outcome over the course of treatment as well. So these are very important concepts. I think we'll probably put this to a halt again for the third case. Come to this next time. We're at about 15 minutes now. I hope this information has been helpful to see how this works in actual patients and what it can do for them. We haven't talked about neurofeedback outcomes related to this, but we will in future sessions, and maybe even come back to presenting some of the research again. If you all have any questions, feel free to list them. If you have any topics you want us to explore, research to review, anything of that nature, have any questions, comments, anything at all, it'd be great to have discussion and dialogue in this group as well. So hope this has been helpful, and till next time, hope everyone has a great week. Bye-bye.